Good afternoon, everyone. Thank you, Professor Puri, for giving me this opportunity to share my experience of CLADS at the Cardiac Center, PGI Chandigarh. I'm Dr. Banashree, Professor Cardiac Anesthesia. So I'll be talking about CLADS in cardiac surgery. Mind you, it is CLADS. I'm not talking about TIVA alone. So the highlights of my presentation would be feasibility of automated TIVA in cardiac surgery, comparison of CLADS with TIVA to manual administration of anesthetic in different populations like adult, pediatric, and patients with LV dysfunction, and CLADS with inhalational anesthetic in cardiac surgery, and CLADS for with TIVA for ICU sedation, and what's the current situation. So I am going to talk about perspective of CLADS, not the technicality that sir has dealt very well. So what are we looking at in our future? So when I was asked to talk on this, I was searching. So I came across this infographics from Anesthesia Analgesia 2022 February, which shows that how anesthesiologists practically are good leaders of healthcare organizations. So we are not stopping at OR. We are taking ourselves to build the healthcare organizations and lead them. So where do we get the time? And why do we have this capability? Because of our inherent qualities of natural multitasking, of natural communicators and active listeners to all, highly observant to changing circumstances. We are natural collaborators and consensus builders and understand the system level thinking. So where will we get the time for all these things? So after that, okay, I want to be a leader. And what more? I want to be a public health physician. Who am I? I don't treat myself as an anesthesiologist. I'm a perioperative physician, I thought, but now I think I'm a public health physician. What is the definition of public health physician? By CDC, it is anything you do to decrease the disease burden and improve or decrease the morbidity and mortality of the population at a large. So what population I'm catering to is the perioperative population. I might not be going into the open world and coming in contact with everyone, but there are a certain category of people whom I am catering to. So I have to look after their well-being so that their outcome is better. It is not only anesthesia delivery. So this is nicely deliberated here by Moon Singh in Anesthesia Analgesia 2023 April. So my perspective is changing. So in cardiac surgery, does the role of anesthesiologist important? Is there a role that certain kind of anesthesiologist, certain caliber of anesthesiologist is required in cardiac surgery? And yes, this editorial by Brian Maxwell in Anesthesia Analgesia 2015 deliberated on this topic and said, yes, it is important. It is important by a trained anesthesiologist who is giving anesthesia for a person undergoing cardiac surgery that brings a different outcome. So after all this, whatever I think about myself, what do I have in my armamentarium which can make me different from others? So here comes automation, decreasing my workload and giving me free hand, free mind to think about other things which will improve the outcome. So basically the artificial intelligence or the closed loop systems, they are there for anesthetic, for hemodynamic management or pain control or blood glucose control or ventilation, all these things, they have few goals which are common. They are to improve patient care by keeping patient within some kind of physiological target range, reduce variability within the individual and reduce variability among the caregivers, that is encounter variation, provider variation or institutional variation, that's very common in anesthesia practice, and ultimately to improve outcome. And this was deliberated in anesthesiology clinics 2021. So in the closed loop anesthesia, the center of discussion is around a monitoring called BIS. Why it came into limelight? Because of all the studies that were done by the colleagues. One of them is Nirvik Pal, is my senior from AIIMS. They did wonderful studies, and it was as Be Unaware trials published in Anesthesiology 2010, where they studied that in cardiac surgical patients, if the BIS was low for a certain period of duration, it increased the intermediate and long-term mortality in patients. And the same authors did a study among non-cardiac surgery, and they couldn't find the same effect. But still, the other Be Aware trial also, which was done in a different population, including cardiac surgical patient also, they found that monitoring BIS was important, and BIS value of less than 40 for more than 5 minutes was associated with morbidity. So, so the BIS is center of the monitoring which is required. That is very important in cardiac surgical patients. Other study, these studies were in 2010 or 11. The continuing the same journey, the authors have found out another monitoring that is called the triple low, which includes the mean arterial pressure, low BIS and low effector site concentration of the anesthetic. If this triple low is there for more than 60 minutes, the mortality increases by 8 times in patients undergoing cardiac surgery. This is recently in 2017 by the authors, published in Journal of Clinical Monitoring and Computing. So all these things are important. The anesthesia is very important in cardiac surgery outcome. So now coming to the feasibility of a completely automated intravenous anesthesia delivery system in cardiac surgery, I found the study in 2016 by Cedric, and this was published in Anesthesia Analgesia, where the robot was taking care of 3 components of anesthesia, that's the hypnosis, maintaining a BIS of 45, analgesia, maintaining a NOSI map value of close to 0, and muscle relaxation. So they were targeting all the 3 components of balanced general anesthesia, and they found that it was feasible to provide anesthesia with a closed loop system. They studied 20 patients using propofol, remifentanil and rocuronium using the closed loop feedback control. This is 2016, but when I searched further, I was surprised, and it was a proud moment for me that the cardiac surgical studies were done from my institute. So coming back to 2009, this was a study published in Acta Anesthesiologica Scandinavia, where 40 adult patients undergoing elective cardiac surgery under cardiopulmonary bypass were anesthetized using CLADS and manual group, and the automated delivery by CLADS were found to be safe, efficient, and it performed better than the manual administration in open heart surgery. So this CLADS was patented in 2003 in US, UK and India. This system has a controlled variable and a standard infusion pump, which is a actuator. So in this study, the authors have found that CLADS could not perform in few situations like the interference by the electrocautery or the epicardial pacing, which were interfering with the BIS values. And also, as we know, the cardiopulmonary bypass is having effect on the pharmacokinetic of the drugs because of the hemodilution, the cardiac surgery undergoing in hypothermic bypass. So all these have different effect on the blood level of the drugs. So these things interfere in our BIS and the propofol level. So this was also found in the study. Another finding was that they were also able to maintain the hemodynamics using phenylephrine in the study, and they found that the use of phenylephrine was less when the anesthesia was delivered by CLADs. In 2013, another study by the authors, it was published in Pediatric Anesthesia. They found that children of age 5 to 18 years, 40 children undergoing elective cardiac surgery under cardiopulmonary bypass were given anesthesia by closed loop anesthesia delivery system, and the combination of three findings, equivalent timing to induction, lower dose of propofol, and no overshoot of BIS, suggested a potential advantage of computer assisted drug titration in anesthesia compared with manually controlled regimes. Another study by authors from PGI, it was published in the Journal of Clinical Anesthesia 2017, where they have given anesthesia to a patient with moderate to severe left ventricular dysfunction using closed loop anesthesia, compared it to target control infusion, and they have found that it is feasible to deliver anesthesia with closed loop delivery system. The important finding in this is that in a low cardiac output situation, the drug effect side drug is less to give a equal effect on the BIS. On this study, the same journal, the editorial was written encompassing this use of CLADs or TCI in cardiac surgical patients, and it was deliberated that they have their own role in anesthesia for cardiac surgery, having there some disadvantages or limitations. For example, all these studies, they are done in elective controlled situations. They have not done in a very sicker kind of patients, obese or having multiple comorbidities, except the LV dysfunction study this was done. So the more and more studies are needed to be done to encompass different patient population, because in cardiac surgery we are having complex congenital, having multiple complex aortic surgeries and emergency surgeries as well. So the evaluation of closed loop anesthesia delivery for propofol sedation in post cardiac surgery. Cardiac surgery, anesthesia for cardiac surgery does not limit yourself to the OT. It has to go to the intensive care unit where the patient is being ventilated post-operatively, and then you get extubated, and then the rest of the so this CLADs, again the study is from our institute, and they have shown that it is feasible and equally effective, or it is better than the manual group for providing sedation in the post-operative ICU. Now the second important finding is, while providing anesthesia in a cardiac surgical patients, the hemodynamic stability has to be maintained at all cost. So this is a meta-analysis by Kong et al. Published in Minerva Anesthesiology 2020. They have deliberated in this review that there are specific challenges of hemodynamic management in patient, because the patient, the hemodynamics are regulated by the autonomic nervous system, and it is peculiar to each and everyone, so cannot be standardized. But still, this meta-analysis showed that the closed loop systems achieved longer duration of heart rate or mean arterial pressure control more than the manual control group, also performing better and having a faster recovery compared to the control group. This review provided evidence supporting the importance of considering cardiovascular variables in the incorporation into the design of the automated anesthesia delivery systems. I am not stopping at TIVA, because the authors from PGI again have used inhalational agent in the closed loop anesthesia delivery system, it was called an improved anesthetic agent delivery system. It was used in 40 patients undergoing elective cardiac surgery again under cardiopulmonary bypass, and the AADS was able to maintain BIS within plus minus 10 of target for significantly longer period as compared to the manual group. So after the OR, the cardiac anesthesiologists also give anesthetic at the cath labs. So there is a study published in Anesthesia Analgesia 2017 where they have shown the feasibility of automated closed loop sedation system successfully in patients undergoing TAVI procedures. And this is the second component that I was saying about the hemodynamic stability. So this system is developed at PGI CLAPS, and it is shown to maintain the mean arterial pressure significantly longer proportion of time than the conventional manual method of providing vasopressor agents. So again, there are studies which have shown that fully automated post-operative ventilation is also feasible in cardiac surgical patients. I'm not going to go into much detail about all these things. So what are the challenges and future directions of closed loop devices and artificial intelligence? Till now, there have been substantial studies among all these systems, and they have shown significant promise, but they are not commercially available till now. And to further push the closed loop innovation, there has to be significant engagement with the regulatory bodies, control systems and software engineering in the coming future. And all the systems have to clearly demonstrate clinical impact and patient improvement in outcome measures. At the last, I will put a little thought about the autopilot system in the operating room. This review article in Anesthesiology, published in 2020, deliberated on the automation that is coming up in the medical technology, and as anesthesiologists we are bombarded with large sea of data always, and there is always a scope of automation in anesthesia, but what is the risk? So the adoption of these new systems should safely requires unintended consequences of automation which needs to be mitigated, and research has to be done as to how automated medical devices can fail. We have to find out what are the loopholes in these automated systems so that we can improve the design, use and training. The clinician should receive training in human system interactions involving vigilance, management of system failures and maintaining manual skills. Whether we are going for automation, your manual skills need to be intact. The leaders in simulation-based education should develop scenarios that integrate equipment malfunction and how we deal with it. Training in alarm management in order to prevent alarm fatigue. Research is urgently needed in how to keep clinicians engaged in patient care where their increased number of tasks are being automated. And the regulatory bodies or societies should develop guidelines to address these new requirements for training and implementations. Thank you for your patience listening. Okay.
Thank you.
Thank you, sir.
Wonderful lecture.